Yeah. Yeah. So I think some of it's finding like those particular exercises where like, man, this really changes that. So like, one of the big things that I've learned like over the years, and we can talk more about this next module since that's treatment phase, but since we're talking about it now, like for the upper extremity, if you're doing weight bearing activities and you take away the capacity to weight bear through the heel of the hand, now we're talking just here, you have to almost like lots of times we're finding in like lower extremities, you have to train that posterior chain in order to like kind of catch up anteriorly. Same thing with the upper extremity. If you can train triceps and through like the posterior side of the shoulder, especially in weight bearing, you can get people to kind of cue out of some of this hip hiking stuff. And let's see if you can actually maintain your weight without those compensations. So some of it's like setting them up. And we kind of, in this section, in this module, you guys kind of read about like the constraints-led approach. So how can you come up with constraints that don't permit that like shoulder hike or don't allow for that, or almost cue them out of it inherently so that you're not sitting there like, no, not like that. You know, you don't have to keep cueing continuously, but you actually find exercises that limit the hike itself. So one of the things that I'll do like with a TRX row, so if they do the row, then they have to do lowering where they're not allowed to pop up and they're just kind of like trying to maintain that. We'll do like a serratus press where you have like a band around and I'm reaching forward, and because I'm reaching forward, I can't go up, right? That's a backwards motion. So using constraints in order to actually change the movement itself. Does that make sense? So we can kind of talk through more of those, I would say, like either independently or like in the next module too, but I would say that's the biggest thing shoulder wise. And then even like that T-spine compensation, that constraints-based approach, kind of like what we were talking about at the end of this module, how can I get the T-spine out of the picture and make it happen? So is it that I actually have to maintain flexion somehow while I'm raising, if you're talking about hyperextension through that spine whenever they're lifting, or do I put them supine? Because in supine, now I'm actually blocking that from happening. So kind of coming up with some constraints that, hey, I'm getting the motion that I want without extra verbiage and extra cueing. Is that helpful? So I do have some tips and tricks there if we want to come back to that. Because yeah, shoulder exercises that you can really limit that some of those compensations we see all the time are very helpful. Cool. How about you, Drew? Or yeah, go ahead, Jake.
I have a question kind of based around this because I have a couple of different cases that I'm kind of fighting with this on. The first one that comes to mind, he's one of my shoulder patients. He had I literally can't figure out how to say this word. It's like a capsuloropathy. Are y'all familiar with that procedure?
Capsuloropathy, like they cut out or change some of the capsule, the joint capsule itself?
That. And essentially they do it typically.
Oh, yeah, that's like where they kind of clean it off. Yeah, okay.
Everything down. He's had like recurrent dislocations for like 20 years. It would like literally just pop out randomly. So in regards to like that case, or I think of like fusions, cervical fusions that come to mind, and some of those other procedures where like the design of the surgery is to just like restrict motion at that joint. Like how long do you typically go down the rabbit hole of like trying to open up these movement options? Because with this patient in particular that had the shoulder procedure, he's like 5 months out and he still like doesn't have a lot of IR motion, and like he has to compensate a lot to get like abduction. And I kind of chased it for a while, and then I was like, well, he wants to get to a higher function, and like he's expressed to me that like what's more important to him is that it doesn't dislocate. He doesn't care if he loses a little bit of range of motion. So I kind of like stopped chasing it as much. But that's like one example. And then just like, again, fusions where there's like now a structural barrier to restoring full range of motion. Like I struggle with like, when do I just like allow that to be a compensation that we do versus like, how long do I pour into this that might be like, for lack of a better term, like a futile cause, because it's just like structurally it's not going to happen.
Yeah. Yeah, I would say the fusion one is a little bit more clear just because of the fact that you're right, that it rather than a restoration, now you're talking about an adaptation. I have to teach this person to move without that particular motion. So like the cervical fusion, I'm not going to get back much side bend. I'm going to get probably about like, I would say you can still usually get like a good 50 degrees of rotation, maybe a little bit more. You're not going to get nearly as much flexion. Maybe you're getting half the motion, and maybe you're getting, again, like half the motion extension wise. Think about the joints that can still move. So like for the cervical spine, my OA still works. So I'm going to use that. My upper cervical, unless they had an upper cervical fusion. I'm thinking of all these C5, 6 people. But yeah, so like the joints that are permissible and can move, those are what you're using to adapt, like you're saying. So it's going to be a true compensation. The shoulder problem where they're doing capsular stuff or frozen shoulder or whatever, those surgeries are actually designed to restore normal function. Now you'd have to read outcome measures to see like, are people actually getting it? But at the same time, what I tend to think about is like the design of the surgery is to restore function overall. So with him, if he's like, if you or him, or if both of you guys are getting a little impatient, especially, I mean, a lot of times it's the patient, right? Like they want to get moving, they want to do higher level things. Kind of like what we said, when whatever they can do in the ranges they have, let's get them doing it. Like, can I get after some things where I'm like here and I'm pushing, I'm doing chest passes with the ball, like some of the things that they need, but are also, quote, like more fun, as long as they're purposeful. But at the same time, like especially rotation in the shoulder, it is so slow to come back. And yet if they don't get that back forever after, extension, flexion, and abduction are always going to be compensatory. The problem with it is probably not immediately right now. Is this a younger patient?
He's like late 40s, early 50s. He used to be a PT actually, so it's kind of
Okay.
yeah,
Like, yeah. Interesting. So yeah, so late 40s, that kind of, it's not a big problem right now because maybe I can compensate a little bit. But if you're talking 10 years from now, he's going to have neck issues. He's going to have a little bit of thoracic stuff going on. Who knows what's happening, like as far as like mobility of the nerves themselves, because you need rotation for nerve mobility, right? So like, in other words, it's the problem is having that, we need to have that long-term mindset, because everybody is going to get like a little bit more impatient about getting some of these ranges back, but rotation is huge. So if you think there's even a possibility of getting 20% back, I would still make it part of your daily treatment. So yes, we're working on some of these other things. We're working on maybe it's some strength in ranges that he does have. And yet let's still keep like stretching or dynamic stretching. Let's still keep some mobility stuff from you. Like you could still be doing like those posterior mobs to help with rotation. Can we be doing some loaded eccentrics that help get back some of that range of motion as we're waiting on it to come? Because it really is something that's worth continuing to pursue because the range is supposed to be there. Now, surplus motion, no way. Like if that was a capsular tightening and that the point of it was limiting dislocations, you're gonna have like, am I fighting for from 80 degrees to 90 degrees? If they're a baseball player and they need that for their throwing and pitching, yes. Tennis player maybe. But if I'm just looking for like daily life, I need to get through, I'm not going to push into that like last 10 degrees because the point of the surgery, like you said, was to not dislocate. And 80 degrees is functional and they should be able to abduct and flex. But if you're noticing like a legitimate breakdown in another plane, like you said, so it was abduction, then it's still worth pursuing that transverse plane motion. Is that helpful?
yeah, it definitely is. I think that's where we like hit the crossroads was like that. And then like we were fighting this, I was fighting this whole thing with him of like, he's very, like I said, he's an old school PT, graduated in like the 90s. And he's very much like, well, my surgeon's protocol said I can't lift more than like 5 pounds until like 12 weeks out, but I should be good to discharge and do burpees with my fitness group at 16 weeks. And I'm like, it's not really how this works. And like, so it was a whole thing. But so it's just, it's like this whole like onslaught of like one thing after the other. And we're finally like doing impact, and we're doing some of the things that he wants to do, and he's integrating into his workouts fine. But it's just like, if you go back to like checking your boxes of like movement options, things like that, it's like I think Mike or someone gives the analogy in the course of like you're writing a sentence with like 12 letters in your alphabet versus 26, and it's like, at what point do we like continue trying to gain those letters? But that was definitely helpful.
Yeah. So my summary of advice, still get after it, because it is so worth it to get that back. Because even like you think about that shoulder, let's say he falls someday, can he handle impact if I don't have any rotation to compensate for the fall? You know, like there's just so many things down the road that would be payment or sacrifice for not getting it back. But kind of like, again, back to Ant's conversation that we had, he was like, let's say you're 70-year-old runners, or your 12-year-old runners that are just really struggling with running. If you can get them 20% better, it's still better than not getting them better. So if your dude's like, hey, I want to make sure that I'm doing wall plyos, I'm doing impact stuff, I'm doing chest passes already, and yet can I just encourage him to keep after getting these back? It'll pay off so much in the long run for like subsequent injuries, because the biggest predictor of injury is previous injury, especially a non-rehabbed injury. But then also, like, again, concurrent joints, like that regional interdependence too. So yeah, for sure. Awesome. Cool. All right. So that's basically that kind of like refine phase. If anybody needs to come back to that, we can. So we'll look at that next phase. We've got body weight competency, right? So back to Ariel's question, the things that we're testing to kind of get into that third phase, we want to make sure they are body weight competent. So for shoulders, maybe you're talking about the weight bearing test, like, can I hold a plank? Can I hold a side plank? Literally just like for a time period. Do I have functional, reaching capacity? Lower leg, can I do a wall squat? Can I do a regular squat? Can I do a Y balance, right? Y balance is like just body weight competency. Can I actually control these motions? Anything else come to mind from anybody for that phase? Trying to look at our stuff here. Range of motion, again, you're going to retest that.
I do a lot of heel raise testing with anybody.
Exactly, because body weight.
Yeah.
Yep. Yeah. So
I don't know if like
again,
anterior top down would fall under that, or because I think limitations in that with that task could also fall under like the strength phase of things. So I guess like from a movement competency standpoint, that could fall under there, but it may be limited by strength as well, I would think.
Yeah,